ये recording का ये दे permission दे. It is showing. Srikant, give a recording permission.
Yes, just a minute.
Yeah, or you start recording.
Now you can record. You are a co-host now.
Yeah. You have started.
Yes.
Yeah.
Yes.
Yeah. I share my screen.
Yes. Yeah, I started recording. I started. Yeah, already started. Yes, I can see.
Hello. और कोई नहीं है यार बोला भाई इतना टाइम जाएगा वितरण की जगह मैं भी निकल गया ठीक है
Mahesh, you can put mute if anybody is listening.
Give him the host, so co-host, so he can mute everyone.
यार ये क्या हो रहा है जो लोग नमाज पढ़ते हैं कि हम लोग पागल हैं क्या
Madam, we have 3 minutes to go. I'll be giving that. You will take 1 minute and your session. You can share after that. You can start the session. 1 minute to go.
Yeah. Mahesh, can you put everybody on mute?
Yeah.
Except me.
Yeah, yeah.
We can start.
Yes, thank you so much. Yeah, so we can start now. So good evening, doctor. I, Shrikant Dhanotia, on behalf of the ADAS, welcome you in IBD Masterclass. We are happy to bring you an expert who can discuss interesting case scenario in IBD management, which will help you in your exams and to take better decision in your day-to-day practice. Today, we are happy to have Dr. Alagammi as an expert in IBD, and the topic of discussion is interesting case scenario in IBD. Dr. Alagammi is a consultant medical gastroenterologist at Meenakshi Mission Hospital and Research Center, Madurai, Tamil Nadu. She has done her D in gastroenterology from CMC Vellore. She has presented various posters and papers in national and international conferences. She has attended various regional and national conferences as a faculty. We believe this IBD masterclass will be useful in your exams and day-to-day practice. During the IBD masterclass, you can post your question in the chat box. So now I request Dr. Alagammi to start today's IBD masterclass. Over to you, ma'am. Thank you so much.
Hi everyone. Good evening to all. There are around 50 participants here. I hope many are postgraduate students. I'm happy to be a part of this IBD masterclass. Thank you for the opportunity to the organizers. So let me start. Shall I start the presentation?
You can just share the screen and start the presentation.
Yes, madam, you can start. Yeah.
So is my screen there?
Yeah, it is
Visible to
visible.
everyone?
Yeah.
Yeah, it is.
Yes, madam, it's visible. It's visible.
Yeah, so I have 6 cases for presentation today to discuss the plus and minus that we faced with these cases. So I have 6 patients. So the first case is a rare IBD association. Second one is where capsule endoscopy helped to diagnose the case of IBD, but how the diagnosis got delayed is the thing there. Third one is a common diagnostic dilemma that we have in everyday OP practice. Fourth one is where there was a decision to make whether we have to poke the patient or operate the patient. And fifth one where we had a dilemma whether to go for colectomy or not. And our sixth one was to decide on the step-up therapy for IBD. So I'll go one after the other. First, I'll take up the first case, which was a rare IBD association. She is a 23 years old female who is a medical student who is pursuing her MBBS at Philippines. She presented to our orthopedician with low backache, right hip pain, and difficulty in walking since 2 weeks. She was evaluated and diagnosed to have bilateral sacroiliitis and right hip arthritis. Serological markers, including HLA-B27, were negative, and she was diagnosed to have seronegative arthritis. In the background, she had been having chronic intermittent diarrhea since 4 years. Chronic, recurrent, painful skin lesions over axilla, low back, perineal region, and groin since 10 years. So over these last 10 years, she had been to many dermatologists and few gastroenterologists, and the final diagnosis was actually not made, and she was treated intermittently with symptomatic medications, and in between sometimes she has received salesopyrin also, but she was never on steroids or any other immunosuppressant so far. With regard to the history of chronic diarrhea, she had been having this since last 3 to 4 years, actually intermittent diarrhea, large volume, multiple episodes per day, non-mucoid, non-bloody, that is small bowel type of diarrhea, associated with diffuse abdominal pain relieved by defecation. She also had history of nausea, but with no history of vomiting. She had been losing weight, particularly over the last 1 year, she had lost 12 kgs. When reviewing her past evaluation, she had a CT and upper J-scopy done 2 years back for the evaluation of the above symptoms with no clue to the cause. Colonoscopy was advised but never done, and she was treated conservatively with antidiarrheals, and sometimes she was even treated as IBS. With regard to the skin lesions, she had been having the skin lesions recurrent since 10 years, particularly over the axilla, both groins, as well as low back and the perineal region, and of late over the breast as well. She used to develop painful swellings, which starts discharging pus, and multiple sinus tracts form over a period of time. So there are a lot of scars in all the above mentioned areas and multiple sinus tracts discharging sterile pus, and those swab cultures were negative. And the exacerbations of such skin lesions was always associated with the exacerbations of diarrhea. But actually diarrhea is there for last 3 to 4 years, whereas skin lesions are there for the past 10 years. With regard to the joint, she had axial joint arthritis, which had been fluctuating over the last 3 years. Recently, she had developed peripheral joint involvements, and she was treated with SASO 3 years back by a rheumatologist for a few months, to which she responded, but symptoms recurred. So we have a young female who is a medical student who had been having chronic diarrhea, as well as some skin lesion, predominantly sinus tract, discharging sinus tracts, as well as arthritis. So you can see the skin lesion, so awkward looking. I felt so pity to see her. See her axilla, it's filled with lot of scars, sinus tracts, discharging pus, and both the breasts had similar lesions, and groin had extensive scarring and lot of discharging sinus tracts. So obviously this is hydradenitis suppurativa. So with regard to GA evaluation, so we did CT enterography. So we had a thought that it could be IBD, obviously. So this CT enterography showed segmental thickening of distal ileum as well as IC junction. MR pelvis was done in view of perianal lesions that showed a long pilonidal sinus tract with abscess, multiple perianal sinus tracts, and few intersphincteric low anal fistulas. Colonoscopy showed terminal ileal ulcers. Actually, the entire colonic mucosa was absolutely normal, and we were actually not able to identify any internal openings of the fistula. They were all looking like anal sinus tracts in the perineal region rather than perianal fistulas. Biopsy from the ulcer reported as chronic inflammation with more than 50 per hypertrophy eosinophils, no granuloma. And segmental biopsy from the colon reported as focal cryptitis in few areas, and final report given by the pathologist was suggested was Crohn's disease. So this is the pilonidal sinus which was removed, which was excised. She had a long pilonidal sinus with abscess. So before considering immunosuppression or anti-TNF therapy, we had to remove the abscess. So the sinus tract was excised by our surgeons. So final diagnosis is we have a patient with small bowel Crohn's with perianal Crohn's associated with extensive hydradenitis suppurativa and enteropathic arthritis. So here are the two studies that I want to quote. Both of them are population-based studies, population-based analysis of this association between the two conditions. This first one that I have quoted is a population-based study of more than 3,000 patients who are diagnosed to have HS, and they were analyzed for the presence of coexisting Crohn's disease. And it was found that there was a significant association with Crohn's disease, but not with ulcerative colitis. The second one is also a population-based, registry-based study where they analyzed 700 IBD patients, a diagnosed case of IBD, who were followed up for next 20 years, and the incidence of HS was analyzed in this group. And it was found that there was 9 times higher risk of developing hydradenitis suppurativa in patients with IBD in comparison to general population. So what is the what is a pathologic association? So both are almost same. What is happening is abnormal immune response to normal microbiota, whether it is gut microbiota or skin microbiota here in HS, or whether it is due to dysbiosis or loss of immune tolerance due to genetic susceptibility is a question. But however, finally what is happening is chronic inflammatory, auto-inflammatory conditions. Both conditions land up in sterile abscesses and sinus tracts, and both the conditions respond well to anti-TNF antibodies. However, not to mutation that is observed in Crohn's disease was not observed in patients with hydradenitis suppurativa. There could always be a clinical misdiagnosis. See this, our patient's groin. You see a lot of sinus tracts, scars. So we could easily make a misdiagnosis that it is a perineal or perianal Crohn's. Actually, both of them will be having draining tunnels, which are actually sinus tracts, but logically, a true Crohn's disease will have a fistula. So the fistula will have an external opening and an internal opening joining the bowel. Whereas here in hydradenitis, it will be sinus tract and not actually a penetrating fistula. So they are less likely to cross the sphincter and they will be predominantly sinus tracts. About our patients, MRI was showing predominantly sinus tracts and only very few intersphincteric, that too low-lying fistula were made. So this clinical misdiagnosis is possible. Unless we think a possibility of hydradenitis, we may not make. There have been studies telling that if we take a biopsy of such lesions and do pan-keratin staining, probably we can differentiate these two conditions. Otherwise, clinically very difficult to differentiate these two conditions. So our patient was started on adalimumab. Actually, she is currently admitted under us. She has received the first dose of adalimumab, and to our surprise, all the sinus tracts stopped draining on day 3 of adalimumab. So she is currently in the induction phase, and subjectively she is feeling very good, and all her arthritis symptoms are coming down, and she started walking. On the day 1 of admission, she came in wheelchair, and now she is capable of walking with support. So however, yet to assess the actual response on a long term. So first case I have completed. This case I am presenting because it's a rare association. Often in exam questions, when we are asked what are the extraintestinal manifestations or what are the skin manifestations of IBD, we often tell erythema nodosum and pyoderma gangrenosum commonly, but definitely we should include this also as a skin manifestations of IBD. So going to my second case, this is a patient where actually capsule helped in making a diagnosis, but I felt very sorry for the patient because we made a delayed diagnosis. So she was a 46 years old female who's a diabetic, who has a well-controlled diabetes, who actually came to us with chronic recurrent abdominal pain. But she did not have any luminal symptoms, no vomiting, no diarrhea, no luminal symptoms, as well as she did not have any constitutional symptoms. She was otherwise fine. So this pain had been going on for the past 2 years, and she was requiring oral or IV analgesic every time, and she also had received a lot of antispasmodics and PPA in the last 2 years history. She is known to have migraine. She was on follow-up with a neurologist, but however, she was not on regular medication. As and when required, whenever she had pain, she used to take some migraine medications. When she came to us, her baseline investigation that we did in the angle of chronic recurrent and abdominal pain showed some microcytic anemia. Otherwise, LFT, RFT, serum calcium, thyroid profile, cortisol, serum ANA, everything were negative. So she carried a CCT abdomen in her hand. Films were available, which was reported normal, and she also had undergone an upper GScopy a few months before coming to us, which was also normal. With pictures, it was available, it was normal. And the important point, she also had a diagnostic laparoscopy done a year back for this evaluation of pain, which was also reported as negative laparoscopy. So if you have a patient who is actually having a recurrent abdominal pain with all the evaluations showing nothing is there except for a mild anemia, and who is having a background history of migraine. So we thought, okay, probably we are dealing with the abdominal migraine patient. So she was treated with and Cybelium, and she started responding. So I felt happy. Okay, we have made some diagnosis. Abdominal migraine patient is having, and she is doing good. For next 6 months, she was on regular follow-up. Every month she used to come. Diabetes was under control. HP was around same 10 to 11 with no overbleeds and no further abdominal pain. 6 months later, she came with fatigue. Suddenly, HP became 7 with an MCV of 69. But however, she did not have corresponding GI symptoms. There was no pain episode in the past 6 months. And so we thought, okay, she's perimenopausal, she's 46 years, and she had been having irregular menstrual cycles and on and off menorrhagia. So we thought, okay, anemia is due to recent perimenopausal bleed. And so she was treated with iron and some medications in consultation with the gynecologist. HP improved over next few months, and there were no further pain episodes since the onset of, since the initiation of beta blockers, and there were no GA symptoms also. 6 more months passed off, and again she came with anemia of 5.6, again requiring transfusions. But this time she had already attained menopause. For the past 4 months, she did not have any menstrual bleed. And so we tested stool occult, which was positive. So then we again proceeded with upper GScopy and ileocolonoscopy as a part of iron deficiency anemia workup in a postmenopausal lady, and both scopies turned out to be normal. And there were no history of overbleed, no pain abdomen also. So obviously she did not have any features of obstruction. So we thought we have to proceed with capsule as a part of evaluation of unexplained iron deficiency anemia. So this is the capsule picture that you could see a lot of ulcers over there, aphthous ulcers, linear ulcers, deep ulcers, circumferentially involving the mucosa causing stricture, so inflammatory stricture. So this is very much consistent with small bowel Crohn's. So this got delayed. So she is on follow with us for the past 1 year, and this diagnosis of small bowel Crohn's was made after 1 year. After being on follow with the gastroenterologist, this diagnosis got delayed. So the presentation was so atypical, like she did not have iron deficiency anemia much to start with, and the pain subsided after the initial pain episode with just beta blockers. How it subsided, we do not know. And now she landed up with significant anemia, and it turned out to be small bowel Crohn's. For this much luminal narrowing, she never had any obstructing symptoms, and actually there were no pain episodes over the past 1 year. So what does the echo statement say? In the presence of at least 3 small intestine ulcers in small bowel capsule endoscopy highly suggests a diagnosis of Crohn's disease, provided the patient has not been taking any NSAIDs for the past 1 month. So this patient had stopped NSAID 1 year back. So this is obviously Crohn's disease. So we made a diagnosis of Crohn's disease. Ideally, we should go ahead with an enteroscopy and biopsy of the lesion to make a histological proof of Crohn's. However, we were not able to do for this patient, and her fecal calprotectin was very high, around 600 to 700 in that range to start with. So we made a diagnosis of small bowel Crohn's, and we started her on steroid induction with azathioprine maintenance. Actually, she is on follow-up since then, and it's already 1 year since diagnosis, and she's doing well. No further episodes of pain or no further episodes of significant HP drop, and she's in clinical remission. So what do we really know? What do we really need to know about small bowel evaluation in Crohn's disease? Small bowel evaluation should always be done in all patients for diagnosis of Crohn's disease, even though if you do not have any small bowel symptoms. This is to be done because we have to assess the extent of disease to decide the treatment. Small bowel can be evaluated with MR enterography, CT enterography, or capsule endoscopy. All modalities are comparable. There have been many studies, comparative studies, and they have shown that all the 3 modalities are equally effective. They have got almost equal sensitivity and equal specificity in making a diagnosis of small bowel involvement in a patient who is diagnosed to have Crohn's disease. But however, few studies have shown capsule to be superior to enterography in proximal small bowel disease. So capsule, however, should be deferred in patients with partial obstruction symptoms or proven stenosis seen in the imaging. So capsule is a good modality to diagnose and follow isolated small bowel disease like our patient. In clinically suspected small bowel Crohn's disease with high calprotectin, note the point, high calprotectin, because if you see a patient with low calprotectin, say less than 50, in such patient capsule is unlikely to show some findings in the small bowel. So if you have a clinically suspected small bowel Crohn's disease with high calprotectin, capsule can definitely help to make a diagnosis of Crohn's even when MR enterography is normal, particularly if there is a proximal small bowel involvement. The point is, if you have a patient with Crohn's, for example, if you have a patient with ileocecal Crohn's, we need not always do an upper GI scopy for the patient unless patient has upper GI symptoms. Whereas we should evaluate the small bowel to assess the extent of disease, because the treatment line may change depending on the extent of disease, whether it is L1, L2, L3, what is the behavior pattern, all those things, what classification we have to make for the patient to decide what therapy we are going to choose for the patient. So we should evaluate the small bowel in all the patients who are diagnosed with Crohn's. Particularly small bowel evaluation becomes more important in this sort of patient where there is an isolated small bowel Crohn's disease. So we'll go to the third case. It's a common diagnostic dilemma which we face day in and day daily in our OP practice. We have this sort of patient confusing us what to do next. So here is a patient who is a 36 years old male who actually presented with PU. He came to our general medicine department of our hospital for PU of 2 months duration. So he had been worked up for fever with all this routine tropical fever workup. Lot of fever workup had been done in the past 2 months, and he has history of significant weight loss over the 2 months. So predominantly we have a patient who came with constitutional symptoms. But the important past history is that he had past history of recurrent perianal fistula since last 5 years, and he had been operated twice for this perianal fistula with no records available in his hand. There was no history of diarrhea. There was no history of abdominal pain or vomiting. CT abdomen, which he carried in hand as a part of evaluation of PUO, showed ileocecal thickening. There were no other skip lesions, and there was no lymphadenopathy, no ascites, no peritoneal thickening. CT chest was also normal. In view of past history of perianal fistula, he was also subjected to an MR pelvis, which showed a low-lying intersphincteric fistula in a single fistula, a simple fistula, primary fistula. Manto was negative. So this is a patient who predominantly came with a short duration of symptoms, constitutional symptoms, with no pain abdomen, no diarrhea, isolated ileocecal involvement, and MR pelvis showing a simple anal fistula. Manto being negative. So this is a colonoscopy picture that you could see there are deformed IC valve with ileal ulcers and ileocecal area ulcers. So obviously the guess was TB, but the point which is irritating is past history of fistula and ano requiring twice surgery. That means a complex fistula. Currently, probably he's having a simple fistula, but fistula that required surgery in the past. So whether it is Crohn's, whether it is TB is the biggest question here. Biopsy was reported as Crohn's. Our pathologist felt it is Crohn's. He reported as chronic inflammation and cryptic distortion, but however, there were no granulomas made out in the biopsy. So we have a histopathology reported as Crohn's, clinically a patient who's fitting into TB but with a past history of recurrent fistula. And the most important confusing point that came in is tissue TB PCR was positive. So we landed up in treating him with ATT. So now we'll review this article. No discussion on IBD will be complete if you do not quote this article. This article is from my alma mater. So this is this review article which focused on differentiation of Crohn's disease from intestinal tuberculosis in India 2020. Actually, it is a many people have contributed, but predominantly it is by Dr. Anna Bulimur. If you see the colonoscopy picture of ileocecal tuberculosis, you will see transverse ulcers. You will see, here you can see transverse ulcers, a deformed IC valve, a patulous IC valve, a contiguous involvement of ascending colon and ileum, polypoidal or nodular lesions, and lesser segments being involved. So this is a characteristic feature of patients with an ileocecal tuberculosis. Whereas in Crohn's disease, you will have linear ulcers. Here you could see that you will see linear ulcers. You will see aphthous ulcers. You can see skip lesions and discrete ulcers. You will see a cobblestone appearance. You can see a fistulous opening as you see here, or a formation of strictures and associated severe perineal disease, or you may see isolated colorectal involvement without a ileocecal disease. So there are certain features which definitely helps us to differentiate between ileocecal tuberculosis and Crohn's disease by doing a proper ileocolonoscopy. However, still we may land up in confusions like in our patient. So we will then depend on radiological findings where TB will have mural thickening without stratification, Crohn's will have mural thickening with stratification, strictures are concentric in TB, strictures are eccentric in Crohn's, fibrofatty proliferation is a characteristic feature of Crohn's, and Combs sign, there is a hypervascular mesentery showing a prominent vasa recta is a characteristic feature of Crohn's, whereas lymph nodes, ascites, and pulmonary involvement, peritoneal thickening, these are all features of tuberculosis. So then coming to histopathology. So you always make a diagnosis of Crohn's based on clinical, radiological, endoscopic, and histopathology, and also microbiology. So everything together only we make a diagnosis of Crohn's. There is no single modality to make a diagnosis of Crohn's disease. So then we depend on histopathology. In tuberculosis, you will see large granulomas, confluent granulomas, and often they are caseating, and the location being submucosal granulomas. Whereas in Crohn's disease, you see microgranulomas, discrete and less frequent granulomas, and they are located in the mucosa or in the pericryptal region. So pericryptal granulomas are seen in Crohn's disease. So if you have to depend on AFB stain is going to be positive. Even in tuberculosis, it is only going to be positive in less than 5% of patients, whereas they are going to be absolutely negative in patients with Crohn's disease. Then coming to tissue TB PCR. So if you have a tissue biopsy sent for a TB PCR, is expected to be 30% positive in patients with tuberculosis because of the paucibacillary nature of the disease. It's not that everybody with TB will have a positive tissue TB PCR. It's only 1/3 of the patient who are going to be positive for tissue TB PCR. So if we have a patient who is having a tissue TB PCR positive, the positive predictive value is very good. So obviously it is going to be TB. But however, the negative predictive value is low because it can still miss a active tuberculosis. The one point here, notable point is, in this study, in this article, it has been mentioned that TB PCR can be occasionally false positive in Crohn's disease. And it is also supported by a case series report by Deepak Amarapurkar, where you can see that they found the TB PCR was positive in established patients with Crohn's disease. So it can, whether it is false positive or coexisting TB, nobody knows. So it can be false positive. That's the point that to be taken from this article. So our patient had a tissue TB PCR positive. So coming back to the case, so based on the constitutional symptoms, short duration of presentation, 2 months, predominantly fever, weight loss, and a CT showing an isolated ileocecal involvement without skip lesions, and a simple perineal fistula which can happen for anyone, and it can happen in TB also. So we thought probably we are dealing with TB as supported by a tissue TB PCR positive. So patient was started on 4-drug ATT. Fever subsided. After 2-3 weeks, he came for review, fever subsided, but 1 month later, he came back with right knee arthritis. So he had a right knee arthritis. So now we have a thought, okay, probably we are dealing with Crohn's and we are wrongly treating the patient as TB. However, how to stop ATT? Tissue TB PCR is positive. Am I dare to start steroid for this patient? His TB means if I'm starting steroids, what will happen? Whether it is going to become a disseminated TB because of me. So a lot of questions coming in. So however, the clue is now still patient is having right knee arthritis. So okay, something has to be done for this arthritis, whether it is reactive arthritis due to TB or whether we are dealing with IBD. Let us start SASO for symptomatic relief. So SASO was started and he started showing some improvement. At the end of 2 months of ATT, he came back with scleritis and worsening arthritis with no response to SASO, and being compliant with ATT and tolerating ATT, he continued to have the same constitutional symptoms which he had because he had recurrent fever. So then we repeated colonoscopy, which did not show any mucosal healing. Rather, new mucosal ulcers happened in the ascending colon and descending colon. So this supports the diagnosis of IBD. So what is the data? If you have a patient with suspected TB, if you have a patient where you have a confusion whether it is TB or Crohn's, you decide to treat the patient as TB. So you started ATT. At the end of 2 months, when you repeat a colonoscopy, it's known that at least 2/3 of the patient will have a very, very good mucosal healing. Absolutely, almost normal mucosa you will see at the end of 2 months of intensive phase. The rest of the 1/3 of the patient, we will definitely see healing features, but may not be absolutely in mucosal remission. Rather, there will be definite mucosal healing. Whereas in our patient, it was not seen and he had new mucosal ulcers favoring the diagnosis of Crohn's disease. So then now at the end of 2 months of ATT, he was initiated on steroids, to which he started showing good clinical response in next 2 weeks. So obviously we continued ATT. Whenever we start ATT, we do not stop in between because we had a tissue TB PCR positive. We did not dare to stop ATT, though we had a confirmed diagnosis of Crohn's disease at the end of 2 months of intensive phase. So we continued ATT. We completed the course of ATT of total of 6 months, and we also treated him as a routine Crohn's disease patient. So he was initiated on steroids, Bisolone 0.75 milligram per kilogram body weight as an induction regimen, to which he started showing good clinical response. After seeing a response and with monitoring of counts, he was also started on azathioprine. Currently, he is on follow-up. All this happened 2 years back. He is on follow-up in his clinical. He is in clinical remission. Repeat colonoscopy was done after 6 months of completion of steroid therapy, which showed a very good mucosal healing. And azathioprine dose was hiked because of few residual ulcers. Now currently he's doing well. He's on 2.5 milligram per kilogram body weight azathioprine, and he's on monthly counts monitoring, and he's doing well. And all his extra-intestinal manifestations also responded very well. So the recurrent perianal fistula gave a clue in this patient, but a positive tissue TB PCR and constitutional symptoms distracted us. So we landed up in treating him as TB, and there was a delay in diagnosis by 2 months. So coming to the fourth case, where we had to make a decision of whether to poke or open. So here is a 27 years old engineer who is symptomatic since 4 years. He came with recurrent abdominal pain, diarrhea, and gradual weight loss of 15 kgs along with anorexia. So he is symptomatic since 4 years, and he had received transfusions in the past for significant anemia. He was evaluated for all the above symptoms 1 year back, and all the evaluation records he had, and all were consistent with ileocolonic Crohn's disease. He had both ileal ulcers as well as entire pancolonic involved multiple skip lesions and cobblestoning, linear ulcers. Everything was like this. Classical ileocolonic Crohn's disease. This happened 1 year back. The evaluation happened 1 year back. But however, he did not properly follow up with the gastroenterologist. He received a short course of steroids and he received a short course of mesalamine, and he went to alternative medicine. So he was on CAM therapy and he was not on proper immunosuppression when he came to us. So when he came to us for the first time, he came with acute abdominal pain of 2 days duration associated with fever, actually chills and rigor, and on presentation his BP was 80/60. So he came with septic shock. Basically, he came with septic shock. So acute abdominal pain and septic shock. So this is a CT. You can see an extensive long segment thickening of the ileum and prominent vasa recta, which is a comb sign, and there is a big collection. So 5 × 6 centimeter collection in the right lumbar region, which is reported as abscess. So probably it is a contained ileal perforation. Clinically, he was not in peritonitis, and there are no other there is no free air in the peritoneum. So we made a diagnosis of contained ileal perforation with active ileocolonic Crohn's disease. So what next? So you can see this is a very, very good review article in this regard, where they have reviewed a lot of case series in this regard, and they have reviewed this. This is a conclusion given by this article. Small abscess as defined by less than 4 centimeters can be treated with broad spectrum antibiotics along with anti-inflammatory therapy, which is predominantly a high dose steroid, which is anti-inflammatory therapy, which is used in these patients with abscesses, because the immunomodulator therapy and anti-TNF are contraindicated in patients with abscess. So broad spectrum antibiotics along with anti-inflammatory therapy with high dose steroids can be used in patients with small abscess. Whereas in patients with large abscess as defined by more than 4 centimeters, we have to plan for an image-guided percutaneous drainage. Either it is an ultrasound-guided or a CT-guided percutaneous drainage along with antibiotics, initially a broad-spectrum antibiotic, later tailored based on the culture sensitivity report, and then with high-dose steroids for anti-inflammatory therapy. Once patient improves, once the abscess improves, then patient can be taken up for delayed elective surgery. And the third option for these patients with intra-abdominal abscess is to take for direct surgical drainage with or without resection of the involved segment, followed later by anti-TNF therapy or immunomodulator therapy. So we have 3 arms. So to decide on the individual patient, whether it is a small abscess, large abscess, whether the patient is stable or unstable, whether the patient is fit for surgery, not fit for surgery, so many things are to be taken into account while deciding what to do for this patient. So in a highly selected group of patients, without stenosis and without fistula. Note the point, without stenosis, without fistula. So if they come with only a abscess, a contained perforation, fistulizing disease which is forming a contained abscess. That patient, if there is no obvious enterocolic fistula made out in imaging, probably you can treat this patient medically. Put a percutaneous drain, start on antibiotics, and then start steroids at the earliest time. So then follow up the patient. A small group of patients, as per the conclusion of the review article, 1/3 of the patient escaped from surgery. 1/3 of the patient escaped from surgery over next to 1 year, not immediately alone. Over next to 1 year, 1/3 of the patient did not require surgery, and they were successfully treated with percutaneous drainage and medical treatment alone. Whereas majority of patients will eventually need surgery, 1/2 to 1/3, 2/3 of the patient may eventually need a surgery over next 1 year. So what is the advantage of doing a delayed elective surgery? A delayed elective surgery appears to decrease morbidity and avoid stoma creation. Nutritional and medical optimization will definitely improve post-operative outcomes. So here is our patient who is in septic shock. So when we have such patient, sick patient who is in sepsis and shock, we cannot start immunomodulator therapy, we cannot start TNF blocker. So we cannot start all these things. So is it possible to give steroids with the abscess sitting over there? So we have to drain the abscess. So we did an ultrasound pictorial drainage for this patient. Appropriate sensitive antibiotics were given for 2 weeks, and there were no external fistula development on removing the drain. A repeat CT after 2 weeks showed no residual collection, no intraperitoneal air. He was put on induction dose steroids, to which he responded very well. He gained 10 kg weight in first 3 months of steroids, and all his GI symptoms started improving very well over 2 to 3 weeks itself. Currently, he is on azathioprine and he is in clinical remission. So here is a patient who was treated with medical management despite having a large intra-abdominal abscess. So this is the algorithm for managing patients with intra-abdominal abscess. So if you have a Crohn's disease presenting with spontaneous intra-abdominal, not a post-operative abscess, so spontaneous intra-abdominal abscess, as suggested by imaging studies like a CT or an ultrasound or MR, assess the abscess size. If you have a small abscess less than 4 centimeters, opt for a medical treatment. So it's not that whenever we see abscess, we have to give the patient to surgery. It's not like that. So if you have a small abscess, take the patient for medical management. Start on IV antibiotics, and definitely this abscess is found because of active inflammation. So you should give anti-inflammatory therapy where you opt for high-dose steroids. So look for clinical improvement. If there is a failure, consider surgery. Plus or minus stoma creation depending on the patient. If there is a clinical success, but there is presence of stricture or fistula, patient has improved with medical management, but patient has a significant stricture or a fistula, then you have to take up the patient for delayed surgery when the patient is clinically stable. If there is a clinical success, if there is no stricture, no fistula, then medical management alone is sufficient, and where you put the patient on immunomodulator or biological depending on the primary disease for maintenance treatment. Whereas if the abscess is large, like our patient, where we have to go for a percutaneous drainage. If percutaneous drainage is not possible for some reason, for example, a multiloculated abscess, a deep-seated abscess, or multiple abscess, where percutaneous drainage is not possible, you can directly take the patient for surgery, which is very effective and actually the most effective treatment for an intra-abdominal abscess. If percutaneous drainage is possible, then it is a success. If the patient is successful, clinical treatment, medical management alone is sufficient. Like our patient, where he was subjected to percutaneous drainage and he was put on antibiotics, steroids, and later initiated on immunomodulator therapy also. And he has been treated only with medical management. Whereas if the medical management succeeded, but still he has a significant stricture which is symptomatic, or fistula which is symptomatic, we have to take the patient for a delayed surgery where the patient is clinically stable. So we would have improved the nutrition, the sepsis would have come out, patient is clinically stable, so surgery success will be better. And definitely it has been shown that the stoma creation is less if we take a delayed elective surgery rather than an emergency surgery. So coming to our next patient, so where we had to decide whether we had to do a colectomy or not. So here is a patient. He was a 26 years old male. Actually, he's a brother of a pediatrician who was brought to us with bloody diarrhea since 1 month. So short duration symptoms, 1 month duration. So he was evaluated few days back outside. Actually, he had a CT and colonoscopy done a few weeks back, and he was put on OP basis. He was treated with mesalamine. He was admitted 3 days back in outside hospital, and then he was referred to us. So he was diagnosed as inflammatory bowel disease colitis, and he was treated with mesalamine, low dose mesalamine. He was on 400 milligram thrice daily. That's all. He was on 400 milligram thrice daily. There were no steroids given. And colonoscopy was showing multiple ulcers everywhere. CT was reported as pancolitis. He was on mesalamine for the past 3 weeks. And over the 3 days back, he had a worsening symptoms, and he developed massive hematochezia for which he was admitted in the same hospital where he was diagnosed to have inflammatory bowel disease. So he had received 5 transfusions in the last 3 days, and on day 3 he came to us. So on presentation, his hemoglobin was 3 grams. He was tachycardic, 140 pulse rate. There was no fever, and X-ray did not show any features of toxic megacolon. Elevated CRP was 30. So we made a provisional diagnosis of acute severe ulcerative colitis with massive hemorrhage. So he had to be stabilized. So he was stabilized with a lot of Paxil transfusions, IV fluid, electrolyte corrections, stool culture was sent, stool clostridium was sent. He was put on full dose hydrocortisone, DVT prophylaxis was started, antibiotics were given to cover infections. So he was supportively managed for 2 days. So we had to stabilize him. Even if we have to take for surgery, we have to stabilize him. His HP is only 3. So we were stabilizing over the next few days. On day 3, there was no response. He was still bleeding. Sister used to take a picture of the bed showing full of blood once he passes stools. So there was no response. So what does the echo statement say? The response to intravenous steroids should be best assessed by day 3. In non-responders, treatment options including cyclosporin, infliximab, tacrolimus, or surgery should be considered. Colectomy is recommended if there is no improvement following 4 to 7 days of salvage therapy. So we have 4 options as per the echo statement, whether it is cyclosporin, whether it is infliximab, tacrolimus, or surgery. Obviously, he has massive hemorrhage. So this is a definite indication for urgent colectomy because he is torrentially bleeding. So we were counseling him for colectomy. So his brother being pediatrician, he readily accepted for surgery, but patient was adamant. He was not at all willing for surgery. He said, let me die, but I don't want surgery. So we had no other option. After so much of counseling, so many people counseling him, he was not willing for surgery. He said, I will die. I don't want surgery. So then, we decided, let us treat with infliximab. And so then we gave a infliximab dose. To our surprise, he had a dramatic response. On day 5 of infliximab, he stopped bleeding. He started passing yellow stools. So it was a very good day to see yellow stools on his bed. So then steroids were tapered, and steroids tapered and stopped over the next few days, and azathioprine was added, mesalamine topical and oral were continued. Then he was put on further dose of infliximab 026, and then once in 8 weeks maintenance therapy. Actually, a follow-up scopy after 3 months was suggestive of Crohn's disease. It was not ulcerative colitis. It was actually Crohn's disease because we saw skip lesions, and CT also showed a ileocolonic fistula. Whereas the previous CT that he carried in hands, we showed only pancolitis, and he had a colonoscopy, we showed extensive ulceration, and he was in a fulminant colitis presentation. So we could not do a sigmoidoscopy biopsy for him, and so we took the outside reports and we treated him as acute severe ulcerative colitis. And anyway, we gave biologicals, and she improved. So actually, what turned out to be a diagnosis was severe Crohn's colitis with massive hemorrhage. So this patient took infliximab for 18 months. He's still on follow-up with us. He's doing well. He took for 1.5 years. He was on infliximab, and he was in remission. Repeat colonoscopy showed a lot of pseudopolyps and healed lesions, and he's doing well. So currently, he is not able to continue infliximab beyond 18 months, and he was in there was a good mucosal remission, and fecal calprotectin came down to less than 150. So currently he's only on azathioprine as maintenance therapy, and he's in clinical and mucosal remission. He's on 2.5 milligram per kilogram azathioprine, and he's in clinical and mucosal remission. So the point here is, if we had operated on him, so many people started pushing him for surgery. We were pushing him for surgery daily. So suppose he had been operated, what would have happened? So this is a review of outcome of doing a ileal pouch anal anastomosis in patients with Crohn's disease. So what does this article say? If you do IPAA in Crohn's disease, there is a high chance of pouch complications in up to 65% of patients, to such an extent that up to 54% of patients landed up in pouch excision and diversion. So probably if we had done a colectomy for that patient at that time, probably we would not have done a IPAA at all, because the resection specimen would have shown Crohn's disease, or if it still showed indeterminate colitis, IBD unclassified, then we would have landed up in an IPAA, and he would have landed up in all these complications. And still he will be having disease in small bowel requiring treatment. So the surgery would not have been actually helpful, other than controlling the massive hemorrhage that was happening at that time. So generally, Crohn's disease is considered to be a relative contraindication for ileal pouch anal anastomosis. So this was an interesting case, eye-opener case. Like we were treating him as ulcerative colitis, but he was actually severe Crohn's colitis. So I thought of presenting this case because it's a very good case. So obviously, clinically, we always find it difficult to differentiate between these two conditions, particularly if a patient is having fulminant colitis. So coming to my last case, it's a very interesting case. The question was, should I step up the ladder or not? So she was 34 years anesthetist profession. She herself is a doctor. The previous patient was doctor's brother, whereas she is this patient itself is a doctor. She came with bloody diarrhea since 7 months. Colonoscopy showing a classical picture of left-sided ulcerative colitis, very typical case, severe grade 4 Mayo, biopsy consistent with ulcerative colitis. So she was put on induction therapy with mesalamine, 3.6 gram oral plus topical, along with oral steroids, because she was fitting into moderately severe ulcerative colitis clinically. So she was put on oral steroid, which was tapered over next 12 weeks. It was not that she was not steroid refractory. She was actually responding. By 4 weeks of steroid, she showed a good response, reduction in stool frequency, improvement in anemia, improvement in global well-being. Everything was seemingly good. But however, even after 12 weeks of steroid tapering, she did not go for complete remission. She still had some loose stools 3 times, 4 times a day, some streaks of blood, some urgency. So she was responding, but she did not achieve remission. So our follow-up scopy was done at 3 months. Being a doctor, we had a lot of more extra responsibility, and she was also more demanding that things should go well faster. But however, at the end of 3 months, we had a follow-up scopy, which showed almost same finding as before, with very minimal features of mucosal healing. Same finding, almost same finding. So then we thought, okay, steroid dependent disease, we are not able to taper steroids. With good dose of steroids, she showed a good response. Now coming down on steroids, she's having recurrence. So we added azathioprine. So mesalamine dose was hiked up to 4.8 gram, that is a full dose, 4.8 gram per day, along with topical foam preparation. So she was on full dose mesalamine, topical and oral, and she was on azathioprine. Steroid was continued because azathioprine is going to start its action late. So steroid was continued in a proper dosing schedule with the proper tapering schedule as well. Azathioprine was titrated with every once in 2 weeks counts were monitored, and azathioprine dose was titrated, and we went up to 2 milligram per kilogram azathioprine. So there was an overall clinical response. Stool frequency came down, anemia improved, global well-being improved. There was no pain abdomen thereafter. But however, she did not achieve complete remission. There were some symptoms. Always, whenever she comes to OP, she will tell, I am not well yet. So that will be the first word she used to tell. We always want her to tell, I am fine, but she always say, I am not well yet. So then we repeated colonoscopy. After 4 months of azathioprine therapy, we repeated colonoscopy. We showed grade 2 lesions in sigmoid and grade 1 lesions in rectum, and still not achieved mucosal remission, as well as in not complete clinical remission, though there was a clinical response. So now 4 months azathioprine, full dose mesalamine, long, not about 5 to 6 months of steroids, we still have a patient who is having an active disease. So now the question comes, so should I step up? So obviously, so I have tried mesalamine, I have tried steroids, I have tried azathioprine. So I thought, okay, she is a doctor, she's going to accept, let me counsel her for biologics. So I counseled her for biologicals. So a lot of counseling, but at the end of counseling, she preferred to go to CMs. So okay, I felt okay, let her go. Let me also be relieved because I had to answer 100 questions during every OP visit. So I thought, okay, go to CMC and come back. Let me see what my professors say for you. So what happened next? Whether the ladder was climbed up or not is the question here. What actually happened is azathioprine dose was reduced to 1 milligram per kilogram. She had a normal counts. I said that we were monitoring counts, and she never had leukopenia. Then why azathioprine dose was reduced to 1 milligram per kilogram? So let us see azathioprine metabolism. So azathioprine, what happens when we take azathioprine? It gets converted to 6-mercaptopurine, and this can be metabolized in 3 pathways, where ultimately 6-methyl mercaptopurine is produced, or 6-thioguanine is produced. These two are the products that we are interested in. 6-thioguanine is the one which produces the clinical response because it interferes with the DNA RNA synthesis, and that it has got a anti-inflammatory, immunosuppression, immunomodulator property. Whereas the 6-methyl mercaptopurine has got hepatotoxicity. So azathioprine can get either converted into 6-thioguanine, 6-methyl mercaptopurine, or 6-thiouric acid, out of which these two are our interesting compounds. So what happens if 6-thioguanine level is very high? The very high level is supposed to be more than 450 picomole per 8 into 10 power 8 erythrocytes, because they are all measured in washed fresh RBCs by liquid chromatography. So you cannot send the stored sample. You cannot outsource this test. We have to do in our own lab. Then only it is possible. Fresh RBC should be subjected to liquid chromatography testing for measuring these two compounds. So if the 6-thioguanine level is more, then we land up in myelotoxicity. If 6-methyl mercaptopurine level is more, then we land up in liver toxicity. So this is what is the thing. So if 6-MMP is more, liver toxicity. If 6-thioguanine is more, myelotoxicity. But if 6-thioguanine is less, then you will not have the desired immunomodulator effect. So 6-thioguanine is the necessary compound here for the desired clinical benefit. So this table is very interesting, and we should understand this. So suppose if we have a patient with low 6-thioguanine and low 6-MMP, both are low, both the byproducts are low, means probably we are giving an inadequate dose. Probably we are giving only 1 milligram per kilogram or 0.5 milligram per kilogram. If you give a low dose, or if you give a good dose but patient is not taking properly, lack of adherence. So in both the situations, both the situation 1 and situation 3, you will see low 6-thioguanine levels and low 6-MMP levels, and the ratio, the 6-MMP 6-thioguanine ratio will be normal because both of them are low. So either it is due to inadequate dosing where we have to increase the dose, or it is due to proper dosing but poor adherence. Compliance is poor where we have to verify compliance and adherence of the patient. So these two situations have a similar test reports when we measure these two compounds. Whereas if the patient having a true drug ineffectiveness, let us say he is an azathioprine non-responder, that patient will have a normal 6-thioguanine level and a normal 6-MMP level. That means we have given a proper dose and proper metabolism has happened. Both the products are produced and the ratio is also normal. So you have a normal byproducts formed, but however patient is not responding. That means we have to switch over to alternative therapy. Either it is a methotrexate or we have to go for biologics. So the situation 1 and situation 3 are where we have to increase the dose of the medicine. Situation 4 is one where we have to switch over the medicine. So this situation number 2 is very interesting. So if you see situation 2, there is an excessive activity of TPMT. There is always a talk on low activity of TPMT where we are interested in finding out patients who are going to develop myelotoxicity. Suppose if I have to go back to the metabolism pathway. So if there is a low activity of TPMT, so if there is a TPMT polymorphism, where there is a low activity of TPMT, then azathioprine is shunted towards formation of 6-thioguanine. So we have a very high 6-thioguanine level resulting in more of myelotoxicity and leukopenia. So that is what is often studied and often showed interest. But whereas if you have a patient with excessive TPMT, then we have a low 6-thioguanine and a high 6-MMP levels. So then the ratio will be high. So 6-MMP is a product which is going to cause hepatotoxicity, whereas 6-thioguanine is the one which needs for a desired clinical response. So when we land up in a low 6-thioguanine level, then we will have no clinical response. We would have given a good dose, but we do not have a clinical response. So these people are called as shunters. They shunt the drug to the 6-MMP pathway. So what we can do for the shunters is we can do a TPMT modulation by adding allopurinol, or we can add a high dose 5-ASA compound. So if you add allopurinol or 5-ASA, what happens is the TPMT is, there's a modulation of TPMT activity, and there is the shunting of our drug towards the production of 6-thiaguanine. So these are called the shunters, and our patient was a shunter. So once she went to CMC, the 6-thiaguanine 6 mmP levels were measured and the ratio was found to be high. So she was put on 100 milligram per day of allopurinol, which is a TPMT modulating agent. So it diverts the production of 6-thiaguanine. So if we produce more 6-thiaguanine, we may land up in myelotoxicity. So when we add allopurinol, we should always reduce the azathioprine dose. So this patient was put on 1 milligram per kilogram body weight per day azathioprine along with 100 milligram per day allopurinol, and she was not put on biologics. However, the story is she never came back to me for follow-up. All these things I followed up over phone with my seniors. Patient just messaged me telling that she's fine after about 6 months of above changes. So she was actually azathioprine dose was reduced and the ladder was not stepped up. So friends, so we have IBD, which has got many phases, particularly Crohn's disease. Diagnosing Crohn's disease itself is a challenge in many situations. Treating IBD is definitely a challenge, but it is always interesting. Very satisfactory to see a patient responding to treatment, but still we have lacunae. Patient complaints very difficult. Practically, once the patient achieves remission, they don't take the maintenance therapy properly and they come back to us only during the next relapse. So it needs a lot of counseling. This is probably because of the high cost of many of the medications. We are thinking mesalamine is such a simple drug. Per day, if the patient has to take 3 doses of mesalamine, it is 60 rupees per day. For an average person, 60 rupees per day, along with other medications, hospital visits, blood tests, very difficult. So acceptance of maintenance therapy is always a difficulty faced in during practice. And one more thing is there is always a big time gap between onset of symptoms and diagnosis. We do see a lot of Crohn's disease patient diagnosed about 3 to 4 years after the symptom onset. So something we have to do as gastroenterologists, something we have to do for this. So we have to spread the awareness of IBD at primary and secondary care level so that this gap can be shortened. Thank you.
Yeah, thank you, madam, for your wonderful presentation. Madam, you have a few questions I have already sent. Could you check the chat box?
Yes, please, questions?
Yeah, it is in your chat box. Could you check your chat box?
I'm not able to open that.
Okay, so that is the
yes, now I have opened.
Yeah, this is a Montek test or Mantoux test.
Mantoux test.
The first question, Mantoux test relevance in present day practice. The question being asked to you.
Mantoux test still we do. Mantoux test still we do. Both Mantoux as well as quantiferon TB Gold we often do in daily practice. But definitely it is not a. We are not going to diagnose TB based on Mantoux test. It may give an additional clue that we are dealing with TB rather than Crohn's disease. But we don't make a diagnosis of TB based on Mantoux test because Mantoux cannot differentiate between an active TB and the latent TB.
Madam, second question is there.
In a Crohn's disease patient with large abscess post drainage. In a Crohn's disease patient with large abscess post drainage and symptomatic improvement, is there a minimum duration of antibiotics, and when can we start induction steroids? Actually, studies have shown that once you drain the abscess and give first dose of antibiotic, you can start steroids on the same day. So we need not actually wait for the abscess to completely resolve to start steroids. Whereas with regard to anti-TNF therapy, we should definitely wait for the abscess to completely resolve. As well as for immunomodulator therapy, we should start only after the complete resolution of abscess. Generally, for a drained abscess, we give antibiotics for 2 to 3 weeks. 2 weeks is the usual duration of treatment. Depending on the sensitivity of the pus, you can decide the antibiotic. Otherwise, broad spread, usually ciprofloxacin, metronidazole started to start, are the antibiotics to given in the beginning and changed as per the sensitivity. Steroid can be given on the day 1. Immunomodulator and anti-TNF should be started after the confirmation of resolution of abscess.
Madam, third question is why CD patient responds to anti-TB medication in some patient? Dr.
Nobody knows.
Nobody
knows whether it is a response or whether it is a relapsing and remitting course, natural course of Crohn's disease that we are seeing as a response. We do not know. Some patients do respond, probably whether ATT is having some effect on the gut microbiota, which is the reason. The actual reason is not known, but small group of patients can show a transient response, but not a long-term response.
Now next question from Dr. Vivek. Role of colonoscopy in acute severe colitis in current day practice.
Obviously, we are not going to do a full colonoscopy. We will do a sigmoidoscopy and biopsy, particularly in a patient who is already on steroids, who is coming with acute severe colitis. We always want to rule out a CMV colitis. So if you do a sigmoidoscopy and biopsy, we can look for tissue CMV PCR, as well as we can look for inclusion bodies to make a diagnosis of CMV colitis. That is a role. That is a role. We can make an alternate, whether it is an alternative diagnosis.
Okay. Now, madam, question and session. I think so that the audience can ask the question directly rather than the chat box.
Yes.
They can ask also, because I have seen a lot of hand raises there. So they can also ask the question. Unmute yourself and you can ask the question to madam. Okay. Madam, you've got a lot of compliment for your presentation.
Thank you.
Yeah. So most of the doctors is here. Anybody is one message I got. Okay, can
tofacitinib used for acute severe
tofacitinib
is useful in the not for acute severe. Tofacitinib is not for acute severe colitis. Obviously, acute severe colitis, there is no data on tofacitinib. For non-responders to azathioprine, moderately severe colitis, definitely tofacitinib can be used. But however, in patients with DVT, you cannot use. One of the contraindications for using tofacitinib is past history of deep vein thrombosis. It's not for acute severe colitis. It is a moderately severe colitis who has not responded to immunomodulator therapy. You can consider tofacitinib.
Just wait for another question. And in between, Dr. Porimal had to say, nice spectrum of cases.
Yeah, thank you.
There's a lot of excellent presentations, a lot of compliment you received, excellent talk and the case selections.
Thank you. Any other questions?
Any other questions? So we don't have a questions. Okay. So any other question? Okay. I don't think so, madam. We have a question. So we go for a formal closing of the session. Srikant, could you share the slide? So on behalf of Zydus, I, Chayan Majumdar, would like to thank all of you for your active participation. This masterclass on IBD, with the help of experience and state-of-art literature, has been truly enriching. It would not have been successful without your precious presence. At the end, I would like to thank Dr. Alagamoi for her wonderful presentation. We believe the learning is a journey, and we will be happy to bring more masterclass for you. We are sure with your support, Zydus will emerge as your most preferred educational partner. Once again, thank you very much and good night.
Thank you. Thank you. Thank you, everyone.
Thank you, madam. Thanks a lot. Thanks a lot for the wonderful talk.